Tetralogy of Fallot by Aubrey Foreman. Tetralogy of Fallot is a congenital heart defect that used to be considered a death sentence for infants in the late century. With the advancements in technology, TOF is no longer considered a death sentence for young infants. TOF is a very interesting congenital heart defect. This is because it is 4 different abnormalities that occur in the order to develop TOF. These 4 factors are an overriding aorta, pulmonary stenosis, right ventricular hypertrophy, and a VSD. Now in this diagram, you can get a pretty good look of what each defect will look like. So pulmonary stenosis is number 1. You can see that you got a narrowing right there. 2, you got a thicker wall, which is right ventricular hypertrophy. 3, you have an overriding aorta, which is a lot bigger and it's shifted. And then 4, you have that ventricular septal defect, which is allowing blood to go between the 2 ventricles. Overriding aorta. One of the first key signs of TOF is an overriding aorta. This is when the aortic root is overriding the IVS. This causes the aorta to receive blood from both the right and the left ventricle. This is abnormal because deoxygenated blood is not supposed to travel into the aorta from the right ventricle. Instead, the blood mixes with the blood coming from the left ventricle and decreases the oxygen level of the blood that is being delivered to the rest of the body. You can see this being demonstrated in the ultrasound image. So right here you can see you have an overriding aorta, and the blood's able to come between the 2 ventricles, mix, and go out to the rest of the body. Right ventricular hypertrophy. RVH is another key factor seen with TOF. This occurs because of the VSD and the pulmonary stenosis that is occurring within the heart. Pulmonary stenosis causes an obstruction that causes the right ventricle to work harder and squeeze harder in order to get the blood to the lungs. Also, with the VSD in the septum letting the blood mix between the ventricles, this causes an increase in preload on the right side of the heart and the ventricles that the ventricle must pump against. You increase the preload, you have an increased wall thickness. Your wall becomes more hypertrophic. With the increase in preload, it causes the right ventricle walls to thicken in order to compensate for increasing the pressure in order to push out the blood, which can lead to right heart failure. So you can see in these images right here how thick the wall is right here. How thick this wall is of the right ventricle. Pulmonary stenosis. This is another hallmark sign of TOF. Pulmonary stenosis is a narrowing of the valve that causes the reduce in blood flow to the lungs. You can tell this by using pulse Doppler to find elevated velocities that suggest pulmonary stenosis. This causes an issue because now the right ventricle has to squeeze even harder in order to push the blood through the pulmonic valve, leading to RVH, which we just discussed. You can see right here, this is a normal heart. Right here you can see how narrow it is near the pulmonic valve. A VSD is the first defect in TOF. This is a hole that is in the septum that allows blood from the right ventricle to go across the septum into the left ventricle. This means that deoxygenated blood from the right ventricle is able to mix with the oxygen-rich blood from the left ventricle. This in return lowers the blood oxygen levels that the infant is receiving to the body. Because of this decrease in oxygen levels, this leads to cyanosis. In the case study we'll discuss in this PowerPoint, you will see that the infants who are suffering from this congenital defect will have many signs or symptoms. For example, blue lips, skin, and nail color changes from the decrease in oxygen levels. Right here you have this VSD, which is that hole, and it's allowing the blood to go between the 2 ventricles. Patient presentation. In this case study, we'll be talking about a 4-month-old infant that was sent to the pediatric clinic that was having severe cyanosis and struggling to gain weight. The parents said the child had an increase in TET spells and had blue lips and color changes. With further investigation, doctors were able to hear a harsh systolic murmur near the left sternal border of the infant, which points towards pulmonary stenosis, which, as we said, was one of the factors that contributed towards TOF. And you can see right here, you can see the changes in the skin of the feet. You got the bluish feet, and right here you got the blue lips, which is a sign of cyanosis. Echocardiography findings. During the examination of the 4-month-old infant, doctors found that the infant had severe cyanosis that was causing the infant to have TET spells and color changes. A transthoracic echo was performed, and the 4 hallmark signs of TOF was present, and it was documented within the exam. Finding 1. The first finding that was found when the test was being performed was RVH. The patient's right ventricle free wall demonstrated severe hypertrophy with right ventricular dysfunction. Looking at the image, you can see how thick the wall is on the ultrasound image. The right ventricle is trying its best to push the blood out and into the lungs, but because it is working so hard, it is causing the right side to become hypertrophic, which means thickening, and you can see that right here. Finding 2. The next finding was an overriding aorta. The aorta was enlarged and overriding the septum. This was making it easy for the blood from the right ventricle to mix with the blood from the left ventricle. This abnormal position allows oxygen-poor and oxygen-rich blood to mix and travel throughout the infant's body, leading to severe cyanosis, which you can see right here. Blood's coming together, it's mixing. You got this large aorta, and it leaves and goes throughout the body. The blood does. Finding 3. The next finding was a VSD found in the IVS. There was a large hole in the septum wall that was allowing the unoxygenated blood to flow in the left ventricle, known as a right to left shunt. This mixture of oxygenated and unoxygenated blood was lowering the blood oxygen levels. This in return causing the infant to have blue lips and TET spells. So right here you can see the blood traveling from the right side to the left, and it's mixing, and you can tell by the different colors right here that you have turbulence going on. Finding 4. The last finding that was seen during the exam on the infant was pulmonary stenosis. Because of the stenosis, it caused an increase in velocities through the stenotic valve. Doppler evaluation demonstrated a pressure gradient of 80 millimeters of mercury across the pulmonary valve, with turbulent flow being seen on the image. This was leading to an increase in pressure within the right ventricle, causing RVH. This increase also caused more blood to flow across the VSD, causing a higher severity of cyanosis. So right here, you got that normal heart, what it should look like. The pulmonic valve, it looks normal, but here you can see that the valve is narrowed, and that because the pressure is increasing, it switched to a right to left shunt, and now the blood's going to be going over here to the left side of the ventricle. Management. Surgical intervention is crucial in order for infants to survive from TOF. Surgical intervention is normally performed on infants who are 3 to 6 months in age. Surgery consists of right ventricle outflow tract obstruction relief and VSD closure. Right ventricular outflow tract obstruction is the same thing as pulmonary stenosis, so don't get confused. This can be done by using a synthetic patch that closes the VSD that is letting blood go through the IVS, and they will also go ahead and do something to open up that area of stenosis in that pulmonic valve. They'll try to open it up so they can get blood from the right ventricle to the lungs. After the surgery, doctors order an echo in order to make sure that the surgical intervention was a success and that no further complications will occur. Long-term outcomes. Because of the advancements in technology and our better understanding of TOF, we have an increase in survival with patients who have TOF. Most patients who undergo this procedure as infants tend to have an improved quality of life into adulthood. Monitoring is still necessary for these patients just to make sure there are no other complications that may occur further down the line. So questions and discussions. I have 2 questions here that I'm going to read out loud, and then we're going to discuss them. So what happens during a TET spell? During a TET spell, it becomes harder for the heart to pump blood into the lungs. This means that the oxygen-poor blood from the right ventricle will instead travel an easy route through the ventricle septal defect, which is the VSD, and into the left side of the heart, where it is pumped out to the brain and the body. This, in return, because that blood's mixing, has a decrease in oxygen levels. So that blood is pumped out to the brain and body, which is causing the blue lips, the cyanosis, which is all considered TET spells. And if this congenital defect isn't fixed, the cycle will continue until it becomes worse and worse and eventually lead to death. So when does a left to right shunt switch and become a right to left shunt across the septum? So when does the blood switch from going from the left ventricle to the right ventricle, and it switches and comes from the right ventricle into the left ventricle? So like we discussed, blood likes to go from high pressure to low pressure. Well, the left ventricle is considered higher pressure than the right ventricle. But with that pulmonic stenosis and the hypertrophy that's going on, the blood isn't able to get through to the lungs, which in return is causing an increase in pressure. And then it's causing RVH because that right side's trying to make up for it, trying to squeeze and squeeze to get that blood out. Well, when that pressure on the right side becomes greater than the left side, that's when the blood will switch directions. It will go from a left to a right to a left. And that's when you have severe cyanosis, because that more blood is going into the left side of the heart, mixing with that oxygen-rich blood and becoming lower in oxygen levels, and is being sent out, which then is causing those TET spells. So that's when the shunt will switch. So that's when it gets worse and affects the body and eventually will lead to death if it's not taken care of in a timely manner. So this is the reference page right here. This has all the sites, and there's also the links to go to the different images that we saw within this PowerPoint. And this is another page that has my other references on it. But if you have any questions, reach out to me. But thank you.